Okay, so breaking down brainstem gliomas. All right, so brainstem gliomas, we're starting here at the bottom, okay? These are a clinical pathologic entity. So there's actually different kinds of brainstem gliomas, and they present in the brainstem. Okay, we have about 4 out of 5 of them are diffuse brainstem gliomas, or diffuse intrinsic pontine gliomas, DIPGs. I see them, unfortunately, about once a month I hear about one. They're very unfortunate cases. But then we also have the focal brainstem tumors, which is about 1 in 5 of them. Okay, focal brainstem gliomas take up a smaller portion of the brainstem. They're smaller. They're well-defined borders. Okay, they don't have the same infiltration or edema of diffuse brainstem gliomas. Okay, they make about 10% of intracranial tumors. It's usually in young kids, like elementary school age, 5 to 9, and more often in boys than girls. Okay, they can often present with vision change and diplopia, okay, due to like lateral gaze palsy, motor weakness, ataxia, very common, head tilting, cranial nerve palsies. So palsy of cranial nerve 6 and 7 are the most common, but can also have 8, 9, 11, and 12. Cranial nerve 3, 4, and 5 are less common. Okay. Duration of the symptoms is a clue to what the histology is. So diffuse tumors, they tend to have a shorter onset of symptomatology. Often they'll say, you know, 2 weeks ago I started having some headaches, and then they think they go away, and then they end up a week later with much worse headache. They go to an ER and they find a mass in the brainstem. Okay, focal tumors, because they're small, and they're often slower growing, they can have a very protracted course with a long history of discrete cranial nerve deficit or a prolongation of the increased intracranial pressure symptoms. Okay, so here's a cross-section of the brainstem. Okay, so a lower pontine glioma will interfere often with the motor function of the ipsilateral side. For example, we have cranial nerves 6, 7, and 8 right here, and cranial nerve 5 right here. Okay, so we have these tumors that are in the brainstem itself and will often affect cranial nerve 6 and 7. Okay, these are the most common. They also can involve the fibers of the middle cerebellar peduncle, the MCP, and because the cerebellum is associated with coordination, then they end up having ataxia. Okay, so here are a couple picture examples. This is a focal brainstem tumor, and you can see here how the border of this is well delineated, circumscribed circular area. The same on this picture here. Okay, and that's in contrast to DIPG, and in this particular picture you can see the tall height of the tumor and extending vastly and actually expanding a little bit the size of the brainstem. So these tend to be diffuse, well infiltrating, not well-defined borders. Okay, there are other tumors here. This is called a dorsal exophytic brainstem glioma, and I've never actually really seen one. But these pilocytic astrocytomas can be sizable masses in the fourth ventricle, and they're attached to the filling the fourth ventricle, attached only to the floor here at the pontomedullary junction, and these can be very indolent. Okay, so these tumors are often resected, and then this is a picture of the same area, okay, 4 years after having radiation for progression after the surgery. So it had resection, was observed, progressed, had radiation, and is right over there. So these actually, they don't tend to enhance. Okay, they don't have much mass effect on the brainstem. They kind of sit on top of it, and people have a very good prognosis. Okay, here's another couple pictures of a DIPG. Okay, here's your T1 sequence on sagittal imaging. Doesn't show up quite as well with the lighting here, but here's the T2, and the T2 is your standard image you want to look at for a DIPG, and you can see it basically taking up the entire area of the brainstem, and they often encircle the basilar artery. That's one of the pathognomonic radiographic signs. Is if it encircles the basilar artery, that is a DIPG. Okay, so for our DIPG, for workup, These don't need to be biopsied. DIPG is actually a radiographic diagnosis in and of itself. Half of them will actually be low-grade tumors, and half of them will be high-grade if you actually get the biopsy. But both low-grade and high-grade DIPGs have the same clinical outcomes. So it doesn't necessarily affect anything, just basically due to the location. Okay, dorsally exophytic brainstem gliomas and focal brainstem gliomas. Okay, these are often in the fourth ventricle, increasing intracranial pressure. Okay, biopsy is often done. These are usually or often pilocytic astrocytomas, so they will often just biopsy them or remove them right at the time of diagnosis, with the expectation of, if this is a pilocytic astrocytoma, they just need to basically remove the tumor, and that is considered curative therapy. Okay, so these will get biopsied. There's another entity, a focal brainstem tumor can occur in the tegmentum. Okay, so this is the top of the brainstem just below the tectum. Okay, and biopsy, if it's unclear what the etiology is, but this can be a difficult area to biopsy, and children can get injured when you biopsy in that region. Okay, so for the DIPGs, you don't have to biopsy, but other ones in general that we will. These days, for DIPGs, sometimes they will get biopsied if they're looking to see what molecular markers they have and to see if there might be candidates for targeted therapy. But those targeted therapies tend to be salvage treatments or only if they're on protocol. And biopsying the brainstem, of course, is associated with morbidity. So we often don't do the biopsy unless there's a rationale to do so. Okay. So the treatment for the dorsal exophytic brainstem gliomas, resection alone can give them very long resolution of symptoms from the obstruction. Okay, you don't need to have a big aggressive surgery because these are very indolent tumors, and aggressive surgery can be very damaging. You just have to debulk them. Okay, focal tegmental brainstem gliomas, these can also be observed actually if they don't have any symptoms. Surgery can be done, and our radiation is reserved in general for progression. Okay. Local control rates, 40% with radiation alone. If they have surgery first, and then subsequent radiation, very high, 80 to 90%. Okay. So for DIPGs, the treatment, median survival is very short. It's less than a year. They're very bad tumors. This is like less than a glioblastoma in an adult. So these are probably one of the worst diagnoses you can have in all of cancer. In over 2-3 decades, we really haven't impacted survival, with exception of radiation. Radiation provides reasonable palliation. It is also believed to improve survival. There's not great data on it, but it is considered the standard of care, in addition to other palliative measures. If they don't have radiation, in general, patients will progress relatively quickly and often die within a couple of months of diagnosis. Okay, so this is a big graph of all these trials for DIPG. They are common tumors in the pediatric brain tumor spectrum, so a lot of studies have been done, and especially because survival is so short, a lot of efforts have been made. Some of the efforts have been to change the fractionation, to do twice daily radiation. We've tried chemotherapy, Temodar, all sorts of things. And unfortunately, none of them have actually changed any of our outcomes. So radiation alone is the standard of care, often with steroids. 54 gray and 1.8 gray fractions with a 1 centimeter expansion for CTV. Anatomically confined. So basically you're contouring the whole brainstem effectively quite often in these types of tumors. You take it all to 54. So dose escalation, hyperfractionation, chemotherapy, none of which have improved outcomes. There have been a number of phase 1 trials. I don't think there is one available right now, at least not a large one. But certainly if the one's available, it's definitely reasonable to pursue that. Okay, can you go to the next one, please?